Okay, folks, we're gonna make a start. My name is Hisha Salami. I come from the University of Otago in New Zealand. I'm the last minute chair for this session. I have the privilege to actually be the chair, as well as to introduce our four speakers. So we have four talks, and we'll allow a couple of questions after kind of each talk. We've got the privilege to introduce the first speaker, Dr. Rathod. We're going to talk to us about the investigation of effects of dietary nitrate on vascular function, the platelet reactivity, and restenosis in stable angina. Right. Yeah. Thank you.
Cool. Thank you very much for the opportunity to present our research. I'll be talking about the NITRATE-OCT study. So coronary artery disease is highest cause of death in the UK, mainly due to myocardial infarction, which occurs when you have an area of the heart that either has injury or death due to blockage of an artery that supplies that area. However, stable angina is still an area of significant morbidity. We have a narrowing within the artery that results in chest pain on exertion. One of the treatments for stable angina is percutaneous coronary intervention, or PCI, where you can deploy a stent within a narrow or a blocked artery to open up that artery. This is very successful and it works very well. There's about 30,000 PCI procedures a year in the UK. However, one of the main issues with this is restenosis. So this occurs when you have narrowing within the stent, which then causes the symptoms to come back. So we wanted to find out if there's a single treatment that may be able to reduce the rate of restenosis in patients who have stable angina and stent implantation. And we believe dietary nitrate might be the answer. So nitrate is found in green leafy vegetables and also root vegetables such as beetroot. So how does this work? So we've known for a number of years the canonical pathway where you can have production of nitric oxide via nitric oxide synthase, which then has the beneficial effects shown below. But now we also have the non-canonical pathway where you have ingestion of inorganic nitrate via green leafy vegetables or beetroot or a capsule, which then can be converted to nitrite and nitric oxide. And I'll talk about this in a bit more detail later on. So our study, the NITRATE-OCT study, included and randomized 300 patients who were in a double-blinded randomized fashion, 150 in each group. So 150 patients received the nitrate-rich beetroot juice, which had 4 to 5 millimolar of inorganic nitrate, and the other 150 had a placebo, which was almost identical, apart from the fact that the nitrate was removed. After recruitment, the patients would receive the juice for 6 months. So on the top left, you can see an angiogram image. This is the angiogram of the coronary arteries, and you can see there's quite a tight narrowing in the left anterior descending, or LAD, artery. This patient then had a stent deployed, and on the top right, the stent is patent. The patient drank the juice for 6 months, either the placebo or the intervention. And on the bottom, you can see they came back for their angiogram again as part of the study. And there's an area of restenosis or re-narrowing. This is exactly what we were studying. So this kind of narrowing would cause the symptoms to come back. What we found in our study as a primary endpoint was that patients who were in the intervention arm with the 4 to 5 millimolar of inorganic nitrate had less re-narrowing or less restenosis compared to the placebo arm, which is shown on the right. So as part of the sub-study, what we wanted to do is look at the impact of once a day inorganic nitrate administration on oral nitrate reduction by measuring nitrate and nitrite levels, and also to characterize salivary bacterial composition by looking at 16S RNA gene community profiling. As I said, we had 300 patients in total with 150 in each group. However, in terms of the sub-study, we had 90 patients in the intervention arm who had paired saliva pellet and supernatant available at baseline and 6 months, and 88 patients in the placebo arm. So the sub-study involved fewer patients, but that's usually what you get with subgroup analyses. In terms of the methods, the salivary microbiome community profiling was carried out by initially extracting DNA using a kit. We then had samples that were subjected to 16S ribosomal RNA gene PCR and sequence using MiSeq. The chemiluminescence machine analysis was used to measure nitrate and nitrite levels in the plasma, urine, and saliva. So we now start looking at some of the results. What we found is the patients who had the inorganic nitrate-rich beetroot juice, shown in purple, had higher rate of nitrate at 6 months in the saliva, plasma, and urine, and the placebo arm did not. So this suggests that, and it's reassuring because the enterosalivary pathway is intact in these patients who have stable angina. And what we found was the reason why they had high amounts in the urine as well, because 75% of the nitrate is in the urine. If we then look at the nitrite concentrations, again, the patients who had the intervention had a significant increase in the nitrite concentrations in the saliva, plasma, and urine. And again, this is because after you ingest the beetroot juice, the nitrate is converted to nitrite by the bacteria that we have at the back of our mouth. And then this is re-ingested, and then nitrite is then converted to nitric oxide by mammalian reductase enzymes. So again, this suggests that the pathway was intact. We then also decided to do a post-hoc analysis of the primary endpoint. So we looked at the dose of the inorganic nitrate relative to their weight and compared this to late lumen loss. So late lumen loss is the amount of narrowing we get at 6 months. And what we found was that there was a significant negative correlation. So the higher the dose of the nitrate you received, the less re-narrowing this was. So this is reassuring and added to the strength of the results. Looking at the bacterial compositions now, so the operational taxonomic units, so there was a significant difference in terms of an increase at 6 months in both the nitrate and the placebo arm. However, looking at the diversity, which is calculated using an inverse Simpson index, there were less diverse bacteria at 6 months in the nitrate group, but no difference in the placebo arm. To look at this in a bit more detail, using an ordination plot based on Primson component analysis of sample composition. In the placebo group, there were no real differences in the composition, but in the nitrate group at 6 months, the concentration of the bacteria seemed to be all together, and this is seen on the top of the graph here. If we now look at the bacteria taxa at 6 months in the nitrate and the placebo group, we saw that there were the Rothia and the Neisseria bacteria group was more highly in proportion in the 6 months nitrate group, and in the placebo arm, the unclassified Streptococcus and the bacteroidetes had a higher proportion as well. Since this is a longitudinal study, we wanted to look at the differences between baseline and 6 months. And in the nitrate group, again, Rothia and Neisseria were more prevalent in terms of the proportion of bacteria present as taxa. So we now look at the mean differences between the groups. So there was a mean difference in the change in the Rothia proportion from baseline to 6 months, with higher proportion in the nitrate group. And this was the same with the Neisseria. So the mean difference in change in the Neisseria proportion from baseline to 6 months was higher in the nitrate group as well. In the placebo, there wasn't really any differences. We know that these change in the groups is related to baseline differences as well. Therefore, we did a regression model where we incorporated the baseline differences. And in fact, after that, we still saw this significant difference with a higher proportion of bacteria, both Neisseria and Rothia, in the nitrate group, and nothing really in the placebo arm. So we therefore decided to hypothesize that do these changes in the proportions of the bacteria have an impact on the nitrite levels? Well, in fact, what we found, if you look at the Rothia proportions first, there was a change, the change in Rothia proportions was associated with the change in nitrite levels. And in fact, in a mixed model where we incorporated the treatment arm as well, there was an interaction suggesting that patients who were in the nitrate-rich group had higher levels of Rothia proportion bacteria, and therefore also had higher nitrite levels. This wasn't seen in the Neisseria group, so there was no association between the change in the Neisseria proportions compared to the nitrite levels. So in summary, dietary nitrate resulted in significant reduction in late lumen loss at 6 months. In fact, about a 50% reduction, which is a huge change at 6 months. There were significant increases in circulating nitrate and subsequent nitrite levels, accompanied increase in salivary nitrate and nitrite levels. The taxa, Neisseria, and Rothia were associated with dietary nitrate at 6 months, and there were significant differences in the mean change of the proportions of both of these bacteria between the two groups, and the difference persisted even after adjusting for baseline bacterial proportions. There was an association between the change in Rothia change and the change in nitrite levels, and this effect of Rothia change and nitrite change differed between the treatment groups. This was not seen in the Neisseria bacteria. So just to summarize all of this, if by taking the inorganic nitrate in the form of beetroot, resulted in sustained levels of nitrite in plasma, which therefore resulted in lower restenosis in the treatment group. And this is all mediated by changes in the bacteria at the back of the mouth, particularly the Rothia bacteria. It's kind of stuck. Thank you very much.
Thank you, Dr. Rathod. I have a question for you. It's maybe obvious, but did you have to standardize the kind of variables that can affect restenosis with intake of nitrates and diltiazem and things like that?
So this was a randomized control trial, which meant that all patients were randomly assigned to groups, and we've looked at all the baseline characteristics. They're all balanced in terms of differences in medication, differences in other variables such as hypertension, hypoglycemia. We did stratify for diabetes because we know diabetes is a higher risk of restenosis, but again, they were equal in both groups.
Yeah, awesome. Thank you. Any questions? Thank you.
Thank you very much for the talk. Blaise Bilek from St. John's University. I'm curious, what volume of beet juice did they consume per day? And was there any kind of carbohydrate burden that came along with consuming the juice? Or?
Yeah, so the juice was a 70 milliliter shot, which they drank in both groups. The nitrate-rich group had a 45 millimolar of nitrate, and obviously the placebo had nothing. In terms of carbohydrate burden, there wasn't a significant burden. We had patients who had diabetes and other comorbidities, and looking at their sugars, there were no significant differences. So 22% had diabetes in both groups. So that wasn't an issue.
Thank you.
Petra Thürmann from the University of Witten-Herdecke, Germany. First, thanks a lot for that very interesting study. Maybe I lost something in the beginning. What was your hypothesis that this nitrate could work or prevent the restenosis? Because in all the clinical trials where patients with coronary artery disease took isosabit dinitrate, mononitrates, etc., with all these drugs, they never ever had a reduction in endpoints. So how do you explain the opening of the patent stenosis?
So unfortunately, due to time, I didn't have the time to go into the details for that. So we're talking about inorganic nitrate, which is found naturally in green leafy vegetables and beetroot. You're talking about organic nitrate. So organic nitrate, which is GTN, isoboronitrate, nitrate, and the mechanisms are completely different. You get intolerance with the organic nitrate and tachyphylaxis because of the way you get the mechanism behind that, which is inhibition of aldehyde dehydrogenase, and therefore causing reactive oxygen species. With the inorganic nitrate, you don't get that, and that's why we hypothesized that this would work. And we also have some, I didn't have time to show you, but cell culture data which showed differences. So if you apply nitrite to cells, they have a decrease in the growth of smooth muscle cells and an increase in endothelialization, which was the basic hypothesis behind the study.
Oh, thank you very much.
Last question, Andy.
Hi, it's Andy Webb. Hi, Krishna, congratulations. This is very exciting work for dietary nitrate, so well done. I had about 4 questions, probably not time. One was, the Rothia is really interesting, how that seems to relate to the conversion to nitrites and association. Is there a way to upregulate that independent, or is just giving dietary nitrate the best way to do that? So if someone doesn't like beetroot juice, for example, and if they existed, would that be a way? Should I ask one question at a time, first time? Or just
I mean,
We just have time for one question. I'm really sorry, Andy.
I want to ask about adherence as well. Could you assess adherence from all those measurements and get an index of that and relate that back to sorry, that was 2 questions.
So in terms of the first question, there may be, if you have other ways of giving nitrate, I think that can increase the proportions. We haven't looked at other ways of doing it, but I'm sure there are. And your second question about adherence to taking the treatment. We had 3 time points where we looked at the levels of the nitrate and nitrite using chemiluminescence because of the large scale of the study. And we saw that there was an increase at 6 months, suggesting they took it. We also had a patient diary, and majority of them did complete this. So we have those 2 ways. In other studies that we've done, we are measuring the nitrate levels at other time points, like 3 months, which would give us more idea of what's the levels here.
Great.
Awesome. Thank you very much.
Thank you.
Thanks.
Yeah, no. No, thanks. But I was thinking about if Rothia is really effective, which it looks like from your data, it's really good. Is there another way you could just enhance a Rothia species?
Sorry, we may have to take this offline because of time. Thank you, though. Thanks, and thank you, Dr. Rathod, for this. So, my next speaker is Mikael Piha, Dr. Mikael Piha, from the University of Turku, talking about Candesartan has no clinically meaningful effect on the plasma concentration of Sub-2C8 substrate in humans.
Thank you, Hesham, and good afternoon, ladies and gentlemen. First of all, a big thank you to the organizers. It's truly an honor to be here to share the results of our recent clinical trial. I'd like to begin my presentation by explaining briefly the specific background of our clinical trial. It is related to the increasing awareness that drug metabolites might participate in or even mediate pharmacokinetic drug-drug interactions. And an important example of this are drug glucuronide metabolites. My Finnish colleagues have demonstrated previously that the co-administration of gemfibrozil and clopidogrel greatly increased the area under the plasma concentration time curve or exposure of repaglinide in healthy volunteers. Now, associated in vitro and in silico research suggests that it is the glucuronides of gemfibrozil and clopidogrel rather than the drugs themselves that seem to mediate this inhibition via time-dependent inhibition of Sub-2C8, since repaglinide is a Sub-2C8 substrate drug. Interestingly, recently, a Japanese group demonstrated that the acyl glucuronide of Candesartan strongly and reversibly inhibits Sub-2C8 in vitro. In the figure on the right-hand side, it's from their paper, and you can see that the acyl glucuronide starts to inhibit the Sub-2C8 mediated metabolism of paclitaxel at much lower concentrations than Candesartan itself. Therefore, it was our aim to study whether the co-administration of Candesartan affects the plasma concentrations of repaglinide in healthy volunteers. We conducted a clinical crossover trial where we randomized 10 healthy volunteers to receive either 8 milligrams of Candesartan or placebo once daily for 3 days. On the third day, we admitted the volunteers to our laboratory and administered them an additional single dose of repaglinide, 0.25 milligrams. After a 2-week washout, we repeated the whole thing with the subjects crossing over to the pre-medication that they didn't previously receive. On the study days, we collected blood samples for up to 9 hours to measure the plasma concentrations of our study drugs as well as their metabolites using liquid chromatographic mass spectrometric methods. And we were particularly interested in the pharmacokinetics of repaglinide, our substrate drug, the pharmacokinetics of Candesartan acylglucuronide, our suspected perpetrator. And since repaglinide is a blood glucose lowering drug, we also measured the blood glucose concentrations. For statistics, we applied pairwise parametric and non-parametric testing when necessary on logarithmically transformed data. In addition, using data from the literature and fresh data from our trial, we analyzed the contribution of certain subenzymes and transporters in any observable clinical drug-drug interaction using something called static drug-drug interaction prediction equations, which I will elaborate on a bit later. You can see the most important finding of the clinical trial on your left-hand side. As you can see, there was little difference in the plasma concentrations of repaglinide between the placebo and Candesartan pre-medication. The plasma concentration time curves are essentially overlapping. And this was consistent with blood glucose measurements, which show that Candesartan didn't seem to modify the effect of repaglinide either. Here are the results in a numerical form, and as you can see in the table, there were no statistically significant differences in the key pharmacokinetic parameters of repaglinide when comparing Candesartan pre-medication to placebo. The peak concentration, time to peak concentration, elimination half-life, and area under the plasma concentration curve. Although there was a small but insignificant increase in the peak concentration after Candesartan pre-medication. Moving on, here are the plasma concentration time curves subject by subject of Candesartan and Candesartan acylglucuronide. As you can see, there is considerable inter-individual variation in the plasma concentrations of both the Candesartan and the glucuronide. However, interestingly, we were able to, using the lower limit of quantitation as a cutoff, we were able to demonstrate the presence of Candesartan acylglucuronide in 7 out of our 10 subjects. This is, to our knowledge, the first demonstration of the presence of the glucuronide in humans. The maximum concentration that we measured was 5.4 nanograms per milliliter. Now, I mentioned the static drug-drug interaction prediction equations earlier. Having obtained now the plasma concentrations of Candesartan acylglucuronide, we were able to estimate its predicted effects on certain subenzymes and drug transporter that are related to the metabolism and disposition of repaglinide. I will just take you through this equation. So this equation shows that how much Candesartan and its glucuronide should have affected the concentrations of repaglinide. This part determines Candesartan and its glucuronide's effect on SUB3A4 in the gut. This part determines the effect of Candesartan and its glucuronide on SUB3A4 and SUB2C8 in the liver. And this part of the equation describes the effect of them on the OATP1B1 transporter in the liver. We did kind of a worst case scenario prediction using scaling up the concentrations of Candesartan and its acylglucuronide according to the 32 milligram maximum clinical dose of Candesartan. So we used as plasma concentration values 4 times 60 nanograms per milliliter for Candesartan and 4 times 5.4 nanograms per milliliter for the acylglucuronide. But even in this worst case scenario, this prediction was in line with what we observed in the repaglinide plasma concentrations. So this prediction predicted no inhibition or increase of the concentrations either. Now, I mentioned earlier that some subjects had quantifiable acylglucuronide concentrations and others didn't. So we conducted a subgroup analysis on the 7 subjects that had quantifiable glucuronide concentrations. And interestingly, in these 7 subjects, there actually was a slight but still statistically significant increase in the peak concentration of Candesartan. And in the spaghetti plot on the right-hand side, you can see subject by subject how the peak concentration of repaglinide changed between placebo and Candesartan pre-medication. The solid lines represent the subjects that had quantifiable concentrations, and there is a pattern upwards, as you can see. To conclude, overall, it is safe to say that Candesartan has no meaningful effect on repaglinide plasma concentrations, and more generally, this indicates that it has low potential for other SUB2C8 mediated inhibitory interactions too, which only reinforces the safety of Candesartan, which is an extremely useful blood pressure agent and drug for heart failure. Of scientific interest is the fact that we were able to, at least to our knowledge, demonstrate the presence of Candesartan acylglucuronide in humans, albeit at very low concentrations. And as was seen in the previous slide, there seems to be a subset of patients who might experience a small inhibition by Candesartan acylglucuronide, so we cannot fully exclude modest clinical CYP2C8 inhibition by the glucuronide of Candesartan. And why this is, it could be that some subjects have higher concentrations of the glucuronide, and it could be that even though our plasma concentrations were very low, that the concentrations in the liver are much higher than in the plasma. I have to give credit of this notion also to the Japanese group, because they speculated with this too, that the intrahepatic concentrations might be much higher than plasma concentrations. Finally, I would like to acknowledge the contribution of my colleagues, both in Turku and Helsinki, and the support from Turku University Hospital Foundation for making this trip here possible. And with this photo, I conclude and finish, and I invite any questions or comments.
Thank you, Mikael, for a nice talk. Any questions from the audience? Right. I just had a slight question, which may not be relevant per se, but your values of below the limit of quantification, how do you deal with them? Do you just actually exclude them?
Pardon, can you repeat, please?
So if you have got values that are below the limit of quantification, how do you do with the analysis? You just actually remove them, or would you remove them and then retest whether your values have changed?
Okay, so if I understood your question correctly, why did we exclude the values that were under the limit of quantification?
I just was asking whether you have excluded them or whether you have kind of included them in sort of a probabilistic way.
Well, regarding the data that I presented here, they were obviously not included. The subset of patients, the 7 patients that I mentioned, volunteers actually, pardon. So these volunteers, all of them had at least one plasma concentration measure of the glucuronide that was over the limit of quantification. So this was a post hoc analysis, so we had to be very strict by how we select the subjects that we further analyze.
Got it. Awesome. Thank you very much. Okay, thank you, Mikael. Oh, sorry, we have one last second question. Would you mind, Mikael, just stand there for a second? Thank you.
Thank you for a good presentation. I'm Cho from South Korea. Would you explain how did you estimate or calculate the sample size of 10 healthy volunteers?
You mean why we chose to conduct this in 10 healthy volunteers?
Yes.
Well, the number of subjects that we chose, it is something that we have kind of used as a standard number of subjects in our previous clinical trials too. And it is a small number, but it is sufficient since this is a clinical crossover trial. And being a clinical crossover trial, we can eliminate the inter-individual variation because each subject acts as their own control.
Okay.
Thank you. Thank you, Mikael. Okay, so my next speaker is Dr. See from Changgung University. And he's going to talk about prophylaxis of topical Levofloxacin for postoperative endophthalmitis after cataract surgery. Thank you, Dr. See.
Good afternoon. I'm from Taiwan. I'm going to present a study about prophylaxis of topical Cravit, whether it can reduce the endophthalmitis after the cataract surgery. And although this endophthalmitis is very rare, but it's very serious, particularly for patients after the cataract surgery. So far, there are two ways to try to reduce using medication. One is called topical antibiotics. The other one is the intracranial antibiotics. So far, no consensus about whether we should use the intracranial antibiotics because it's a low financial incentive and also a low risk for the POE. And also it's a lot of a burden because we need to dilute the antibiotics. And then there's some studies say they fear about toxic antiviral segment syndrome. So actually, the topical antibiotics is commonly used. But we still want to see how the real-world evidence. So the aim of this study is we're using the Taiwan data because particularly the 0.5% Cravit toxin solution, which is allowed to use in Taiwan in 2007. So in this study in Taiwan, we have a national health insurance system, so everyone are involved. So we want to find out the practice about the 0.5% Cravit solution used during the year 2000 to 2018 for the cataract surgery patient. The next one is we want to compare the rate before and after the introduction of this solution using the interrupt time series method called ITS. It's nice that we have the National Health Insurance System established in 1995, and all the citizens are required to participate. So in this database, we have about 23 million beneficiaries in this data. And this system, we have like the registration information, so we know the date of the birth, sex, etc. And also, like for all the claims due to the clinical visit, we have some information about the day, and then the medical diagnosis, medical expenditure, and prescription, examination, and procedure. And during this year, we use either the ICD-9 or 10 to code the diagnosis. And we got the approval from our foundation. So the variable we try to ascertain include the cataract surgery. So we use those payment codes to find out who's involved about the cataract surgery. The next is about the POE, which is the endophthalmitis rate after the cataract surgery. We also use the ICD code. And also, we want to make sure the rate is perhaps due to the cataract surgery. We confirm that event should be appear within 6 weeks after the cataract surgery. And then we also want to find out whether the rate which before and after will be affected by different covariates, such as comorbidity. So we count all these different chronic disease, use the Charleston's Comorbidity Index, CCI. And then to avoid or reduce misclassification, all these ICD code should appear at least twice before the cataract surgery. So it's a big study. We have about 1 million people in Taiwan over 2000 and 2018 to take the cataract surgery. We exclude some patients which is unreasonable. For example, like if they have cataract surgery twice or more. Or we also exclude patients, they have endophthalmitis before the first cataract surgery. We also have exclude some patients have follow-up less than 6 weeks. And if in case some patients have sex and age missing, we exclude them that. And then also because we want to find out when do the endo happen. So if patients have the cataract surgery, 2 surgery, less than 6 weeks, we exclude them as well. So after all this, we have about 1.4 million patients, and it's about 2.28 eyes. Well, so remember that in Taiwan, we have the Cravit approved date would be May 2007. So the statistical analysis, basically, we will plot the things with the calendar year. For example, if we want to know the practice about the Cravit, we plot it over time, over the year. We also plot about the demographic characteristic and CCI and see how this patient varied over time. And then we also plot the rate of POE. The next thing is we do an ITS analysis. What is ITS? Is like we do all the rate plotted by quarters. And because over the years, the patient maybe become older and older, so we use the propensity score stabilized rate for each quarter, and so that we have a fair comparison. In order to get the propensity score rating, we use the GBM model, which have less affected by outlier or misclassification of the model. And then in the model, we put the demographic variable and the CCI in the model. And then how do we know whether we have a fair comparison between different quarter cohorts? We use the ASMD. When we is less than 0.1, it means they are quite comparable among all quarterly cohorts. The ITS look like this. So the x-axis will be the quarter over time. And then the y will be like the POE rate for each quarter. So remember that we have 2007, Taiwan allowed to use the 0.5 Cravit solution. So we have two periods, one called the period 1 before the introduction, and then call it period 2, which is post-interruption. So we look up those rate, and then we put a segment linear regression and see how the slope or how the coefficients change. I'll explain this a little bit more after we see the result. Okay, let's come to the results. This is the volume over a time, which is from 2000 to 2018. We will have about 20,000 eyes have a cataract surgery. And then you can see that in 2007, the Cravit percentage will be grow a little bit from 0%, and then till 2018 will be about 30%. The cataract surgery patient will use Cravit. And this is the age, male, and the CCI characteristic over the year. So the blue line, which is without the propensity score rating, and the orange line will be after the propensity rating. So basically, for the age and male, it doesn't matter whether you propensity score rate or not. But for the CCI, it seems when you don't wait that, when the times go later, they will become older. But after we do a propensity score rating, it seems they are quite similar over the year. And then the main finding will be like how the POE over time. So in the period 1, you can see that before we don't have the Cravit, actually the rate will be reduced. And then because during 2007 and 2009, we only have about 5% using Cravit. So we start to compute the period 2, which will start from 2010. So remember that a complicated graph. So actually, we want to use the ITS to find out all these regression coefficient. So for the slope, which is a beta 1, even though without any Cravit introduction, in fact, in Taiwan, it already have a reduction of a POE rate. And then for the level difference, which is for beta 2, is after the Cravit introduced in Taiwan, we see a level change in significance. And then for the slope, actually, we don't see any change because after 2010 to 2018, it seems the rate is become a flat, not reduced anymore. And the very first one, which is without the propensity score rating, this one is quite similar, which is after propensity score rating. The propensity score rating, the basic idea is try to make sure all the rate in different quarter, they are quite balanced. So in fact, we see a similar result without with propensity score rating. So in discussion, the Cravit use before the introduced. So from the year 2000, 2007, we have 0% use Cravit. And then after 2007 to 2010, we have about 5%. And then later on, increased to 30% in 2018. And then we see the POE rate, which is per 1,000 eyes, would be like of about 4 in 2000, and reduced to 3 in 2007. And then it became about 2 between 2010 to 2018. So the ITS revealed that that's a significant level drop of the POE rate. It's about 0.91 per 1,000 eyes after 2010. However, I don't think the Cravit is the main reason to explain the drop of the POE after 2010. The reason is because we still have some other way, perhaps like sterilization, like for the patient, medical equipment, or device and medical staff improve over time. It doesn't work. Okay. And also remember that other than the topic antibiotics, we also have the intracranial antibiotic prophylaxis. But because like the physician have to dilute the solution and it's very cheap, such that that data is not included in my data. So we don't know like the percentage of intracranial antibiotic prophylaxis in our cataract patient. So the POE rate after the cataract surgery is still quite high in Taiwan, implying that topical antibiotics may not be good enough to reduce the POE rate. So in conclusion, in Taiwan, from our study, we know that after the Cravit use allowed in 2007, it slowly increased to about 30%. And then the rate for the POE dropped from 4 in 2000 to 3 in 2007 and become 2 between 2010 and 2018. Okay, finally, the ITS reveals that we saw a significant level drop of the POE rate after 2010, but as I mentioned in the discussion, may not necessarily due to the Cravit use. Okay, that's the end of my talk. Thank you.
Thank you for that, Dr. See. I was gonna just ask a simple question. Does the rate in Taiwan compare to other countries?
Which way?
For POE?
Actually, slightly higher.
Slightly higher.
Yeah. Yes.
And the kind of the practices are similar around the world, or do some countries have different intervention than Taiwan?
Other than topical or intracranial, because for the intracranial, first of all, I asked my ophthalmologist. I'm not an ophthalmologist, I'm a biostatistician. So you can see that I can explain the method pretty well, but not the clinical. But I asked my colleague, who is an ophthalmologist, actually his thing, intracranial is a better way to reduce the endophthalmitis. But it's just because it's very cheap to dilute the solution, and then it's very easy, so we don't see that data.
That's fair enough, thank you. Any questions from the audience? Yes, we have one question there.
Hello. Thank you for this very nice presentation.
Thank you.
I think you have a wealth in the sense that having this important database, which includes all the population and all information from all the population, is very interesting for performing these kind of studies. You know, for me there is a concern when using topical, or what you say, you use topically diluted levofloxacin, no? Because levofloxacin is an antibiotic that can produce QT prolongation. So I don't know if you could also, in parallel, measure or identify the cases of how the frequency of QT prolongation in the population according to the increase in the administration of this antibiotic. Because also cataracts are mainly performed in older patients, so there might be also an important increase in QT prolongation. And for me, this is a very important concern.
Thank you. I'll try, but it's a lot of work, and still a little minor revision we are coming in. But I will take your message and discuss to the ophthalmologists and see what we can do. Thank you.
Thank you, thank you.
Thanks. Are you aware whether there's kind of any systemic absorption from the topical? Is there like massive absorption of the drug once it is injected or applied topically? Is it going to get in the circulation? Are you aware?
I don't know.
So, yeah,
Sorry,
that's
as I
all right.
mentioned, I'm not an ophthalmologist. I'm a biostatistician, so it's harder for me to know the basis behind that or mechanism.
That's fair enough.
But I'll try to bring the message home. Thank you.
Well, thank you again. Cheers. So, the last but not least, we have my fourth speaker, Dr. Raul Andrade from the University of Malaga, and talks about the influence of prior drug allergies and drug-induced liver injury analysis from the Spanish DILI Registry. Thank you, Raul.
Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. First of all, I would like to thank the scientific committee for selecting our abstract for oral presentation. It's not...
I think it's happening very, very soon.
Okay. Well, nothing to declare. Well, allergic drug reaction belong to is really a subtype of type B unpredictable adverse drug reaction. There is recent data indicating that there is a steady increase in hospital admission due to drug allergies, particularly in older patients over the last decades. The influence of prior drug allergy in the phenotype or the outcome of idiosyncratic drug-induced liver injury is not well known. Actually, there is only this study, a retrospective study using electronic medical record for identifying patients with prior drug allergy and patients with idiosyncratic DILI with and without prior drug allergy. And in this study, there were really small differences between the groups. The group of prior drug allergy accounted for 23 patients, and there was a higher frequency of female in this group, but severity was not different between the two groups, as you can see in the slide. One important limitation of retrospective studies in idiosyncratic DILI is the fact that causality assessment is inaccurate in many cases because of missing data. So there are no studies conducted in a population of patients with well-characterized DILI. So the aim of our study was to compare the clinical presentation and outcome of DILI in patients with and without prior drug allergies, and to assess the association between the drug responsible of DILI and prior drug allergy. The patients were collected from the Spanish DILI Registry, a registry that was set up in 1994. Cases are submitted in a DILI report form, which includes detailed clinical history. So we look for the history of prior drug allergy, and we exclude from the analysis patients who had allergies non-related to drugs or non-properly documented. So in total, we have 912 patients with a first episode of DILI, and we exclude from the analysis patients with intrinsic DILI, patients with rechallenge episode, and patient with a second episode of DILI due to a different drug. So in total, there were 61 patients with confirmed prior drug allergy, which accounted for 6.7% of the whole series. Looking at the differences in demographic variables within these two groups, you can see that the patients with prior drug allergy were older and had a greater frequency of underlying hepatic disease. And looking at laboratory data, there were, in the patient with prior drug allergies, there were lower, an average lower platelet count, and interestingly, there was more severity, with 15% of the cases evolving to liver-related death or liver transplantation, as compared with only 3.1% of the cases in the group with no prior drug allergy. Looking at the drug responsible for DILI in cases without prior drug allergy, as is frequently happened in most series, amoxicillin clavulanate was the leading cause, followed by anti-tuberculosis drug, herbal and dietary supplements, some specific drugs such as ibuprofen, flutamide, or atorvastatin. Looking at the most common drug responsible for DILI in cases with prior drug allergy, again, amoxicillin clavulanate was topping the list, followed by evrotidine and herbal dietary supplements. Evrotidine was a H2 receptor antagonist that was marketed in Spain in the last decade of the past century and had to be withdrawn from the market because of serious hepatotoxicity, including liver-related death and liver transplantation. And looking at the most frequent drugs responsible for the prior drug allergy in DILI cases, penicillin was topping the list, followed by codeine, acetyl salicylic acid, and other drugs accounting for minimal fraction of cases. This network plot was intended to show the relationship between the drug causing drug allergy in red with the drug causing DILI in blue. And we found that 28% of the cases, in 28% of the cases, the drug causing drug allergy and the drug causing DILI belong to the same drug class. So we also compare the patient who had a fatal outcome in the group of prior drug allergy with those who didn't have this worse outcome, and there was in the former group there was a greater frequency of jaundice and hospitalization, and total bilirubin levels, aspartate aminotransferase levels, and lower platelet counts at DILI onset. In other words, the patient had more severe presentation, patient with prior drug allergy. So we use a machine learning approach in order to, through a multivariable regression analysis, to identify factors associated with fatal outcome in this population. And this statistical tool identified 6-factor prior drug allergy hepatocellular injury based on the new R. New R means that the ratio between ALT in false upper limit normal and alkaline phosphatase in false upper limit normal to determine if the liver damage is hepatocellular or cholestatic or miss is instead of ALT, we use AST or ALT, whichever is higher. So this was based in this new R, female sex, total bilirubin, aspartate, aminotransferase, and platelet count. And to look and to show you how this can be translated to clinical practice, this is a predicted nomogram. Actually, a calculator of the risk of developing a worse outcome, liver-related death or liver transplantation, and categorical variables were plotted in box in orange, and continuous variables were plotted in bars in green. And to illustrate for example, how this works. This is a case patient who had prior drug allergy, and in the bottom of the slide you can see that the probability of developing liver-related death or requiring a liver transplantation was 43%. In contrast, a patient who didn't have or without prior drug allergy had a probability of 2% of developing this worse outcome. So we internally assess the performance of this model. You can see in the left part of the slide that the area under the curve was good, and we also externally validate the model in an independent data set of the American DILI Registry, and you can see that the area under the curve was also very good. So in conclusion, this is the first study that analyzes the role of prior drug allergy in a large cohort of well-characterized DILI cases. Our data show that drug allergy may be an independent predictor of fatal outcome in DILI. That patient with suspected DILI should have a thorough pharmacological history and be screened for prior drug allergies because of the prognostic value, and the DILI patient with prior drug allergy require close monitoring for early detection of worsening clinical course. I would like to thank and to acknowledge all my group and, of course, all the national and international collaborators for making possible this presentation today. Thank you.
Thank you, Dr. Andrade, for such an interesting talk. I was going to ask you something that is slightly different in the sense that are there patient variables that can predispose someone to this? So have you looked at obesity, or things like alcoholism or alcohol intake? Does that contribute to a DILI?
You mean other factors that are predisposing? Yes, actually the other factors aside from prior drug allergy have been identified in prior analysis from our group and other groups as predictors of a worse outcome. For example, female sex, the pathocellular type of damage, low platelet count, or AST, elevated levels of AST or total bilirubin. So this is the new factor that we are being able to identify in our analysis.
That's awesome. Thank you for that. Any questions from the audience? Awesome. In that case, could you just thank me again? Join me again in thanking Raul and other speakers. And you're now free to go and have a break. See you later.
Thank you.
Thank you for this.